Our next question comes from Tessa in Alberta. Is it worthwhile to get the appropriate testing done now, even though the procedure to remedy the situation is not yet available in my area? Now, Karen, I just want to ask you, we're going to ask Dr. Murray here too, but we've just heard about the testing, that it's not that simple, that there are potentially unclear results. What do you think? Have you thought of getting tested?
I haven't personally, but I do know people that are very interested in getting it done and have looked into going to Buffalo and that sort of thing. I haven't personally, only because it's a personal choice. When this becomes a clinical trial, I'll have my hand up first to definitely join. I've taken part in clinical trials in the past. I think it's very important, you know, to study the disease, of course, because that's the only way that, you know, to find the cause and to find ultimately the cure. So I have taken part in clinical studies in the past, and I'll be jumping on board if this becomes a clinical study for sure, but I haven't as of yet, no.
Dr. Murray, then, about the testing issue.
I don't think so, because there isn't a set protocol now to tell how the testing should be done or what's the accepted procedure. Also, if a person were thinking about having the testing done and perhaps in a year or later having the treatment given, there is no way that a surgeon is going to do the procedure relying on a test that was done a year or two before. So that you'd have to have the test all repeated again. And again, your point, Aaron, is that once there's a clinical trial, then they'll set up a protocol that says this is the way the test is done and this is the appropriate way to deal with the results. Just to get a test now probably wouldn't be very helpful.
That is from Sheila, who's been living with MS since 1987, and she is asking our panel if she underwent just a form of a test to find out if her veins were blocked, but then decided not to have any procedures done. What are her risks? What's her situation just from having the testing done and finding out that her veins are blocked? Dr. Murray.
I'm not sure we know the answer to that. We do know partial answers. One is that we want to know what the relationship is. In other words, if you have blocked veins, what the relationship is to MS. But the second thing, we know from the Buffalo study that 25% of people who don't have MS have blocked veins and doesn't seem to cause them any trouble. So having the blocked veins, we're not certain about. And we also know that there are some MS experts who are doing studies on this now who wonder whether we're dealing with a secondary result rather than a primary one. In other words, something that's associated with MS but not a cause. One of the things we do not know is this the cause of MS? But that will be addressed. If you think of it in terms of whether or not it's the cause of MS, you have to explain then why half the people with MS don't have it.
Hi, my name's Wendy. I was diagnosed in 2004. You've indicated that the imaging process, there's different processes, I gather, and different types of equipment. Did the Buffalo study use exactly the same equipment that Dr. Zamboni used? Because you're comparing his results with the Buffalo results, yet potentially there's a difference in the actual imaging equipment, which could explain some of the differences in the results.
That's a good point. But in fact, they did. And they had Dr. Zamboni as one of their one of the people who, in fact, visited and spoke and helped them with their project.
And again, that was a question about the testing that was done in Buffalo as compared to the testing that Dr. Zamboni used. We have a question coming to us from Teresa in Ontario via Facebook. Can a person who's diagnosed with relapsing remitting MS for over 10 years have both CCVSI and too much iron in the brain and still have an ordinary blood test that shows their iron levels are low, too low, almost anemic? Dr. Murray.
Yes. In fact, there's no relationship between your blood level of iron and this hypothesis that iron deposits in the brain might be an issue here. So treating or non-treating your iron level in your blood has nothing to do with this particular question. And the issue is not specific to MS. It has been noted that in neurological diseases that have inflammation as part of their process may accumulate more iron in the area of damage than normally seen. Now, we don't know whether, again, that's a secondary effect or whether the iron is causing part of the problem. But in Dr. Zamboni's hypothesis, it is a separate hypothesis. You have the vein issue, and then there's this issue of iron. But in the last decade, there's been increasing interest in a number of inflammatory diseases of the nervous system to see what the role is of what appears to be a slight increase in iron in many of the areas. So you don't need to evoke the iron concept to deal with the venous one, but he is related to the two. But altering your blood level of iron has nothing to do with the deposits in the brain.
Questions, and first one dealing with the statement from the MS Society, Eva, if I can refer that to you, concerning the CCSVI testing that is being done outside of established clinics and protocols. Eve?
I thank you for the question. Let me start by answering, by explaining that the Society's role in this context is to provide guidance, information based on timely, accurate, hopefully relevant information, but to ensure that our role is as a provider of the information and that we have as a value to honor the right of people with MS to make their own decisions. So I want to make sure that that's clearly understood. In the context of CCSVI, we are, as Dr. Zamboni himself noted in his conclusions, at a very early stage, very preliminary stage in the process of discovery. And the reason we recommend that experimental treatments be sought in the context of clinical trials is really twofold. One is that a clinical trials provides appropriate safeguards for the participants, for the patients, through things like ethical approvals, consent. And secondly, clinical trials provide the appropriate protocols for the information that flows from the patient's response to the therapy in a way that can be rolled up and that becomes data that provides the answers that we need very urgently. So the reality of our position is that it balances the role that we play in serving the interests of people with MS who want discoveries today, therapies today. And we understand that. Living with MS is not easy. MS changes, progresses. It can be very debilitating. But we also want to combine that with the role that we play in racing to those answers that are important in adding to the arsenal of therapies that help us in managing the disease, in slowing its progression, and obviously, eventually, in bringing us to a cure.
Dr. Murray, I'm throwing this one out there for you. This again is from our question. This is referring to, I believe it was a study or a news report that was released on March 29th concerning medications.
Yes.
I don't know if you're familiar with that.
But again, that's an initial study which will require validation, but it is suggesting that there may be a marker that could identify people who would be responsive to the therapies as opposed to those who may not be responsive. The idea that we should recommend that people not take the therapies because of this initial report isn't in keeping with the results. In other words, we have good evidence that patients treated with these therapies, particularly early and when they're relapsing and remitting, get substantial short-term and long-term benefit. So we would not discontinue those therapies. What would be interesting from that study is if they can develop a marker that can be validated, that it can separate patients. Then you could decide that some patients go on those therapies and others not. At the present time, even as a group patient, there is substantial evidence of benefit in those patients. And the results with those therapies is better now than it was initially in the trials, because in the trials, patients who had the disease quite a long time were included in the trials. Now, almost everybody who goes on the therapies goes on them early as relapsing and remitting. And so the benefits now are even greater than they were shown in the trials.